We move on to our next speaker, Dr. Shamira Perera. Welcome to this vast session of the Glaucoma Subspecialty Day. And I take this opportunity to thank you personally for contributing to the GSI guidelines, which we published during my tenure as Secretary of GSI. Thank you very much. And over to you for your talk.
Thank you very much for the kind introduction, and it was a great pleasure for me to form part of your guidelines. Excellent. So I'm going to be speaking to you about a common topic that we often have to see at the extremes of our cataract management. This is the surgical treatment for nanophthalmos. These are my financial disclosures. Now, just to give you a little bit of background about these cases, they are very prone to developing angle closure glaucoma, and the basic problem is that the lens is relatively large for the small eye. There are multiple mechanisms at play here, including the pupillary block, the plateau iris configuration, the choroidal expansion, and the forward lens movement. Now, the lens extraction relieves the angle closure in nanophthalmos very well. However, the visual outcomes for cataract surgery in nanophthalmic eyes are highly unpredictable due to the high refractive surprises and macular changes that can occur after the surgery. The basic classification of these eyes is those that have a short ACD and a short axial length. And there are several different types of this, but essentially they all have the small cornea, a shallow ACD, marked iris convexity, and potential for uveal effusions, which can be potentially sight-threatening. They also have this thickened sclera on choroid. Now, I'm going to be taking you through one of the cases that I recently dealt with, which is quite extreme, 15.2 millimeter eye, plus 17 diopters when they started off, and there's a 5 millimeter thick lens in there. There's 2 millimeters of thickened sclera as well. And this is what the eye looks like on the other side. Again, similar kind of appearance, except with a crowded looking disc and also the engorged vessels. Let me tell you about a case that didn't go so well. This is actually courtesy of Michael Coot, and he told me about this case that was even more extreme. It was under 15 millimeters, and the eye that had a potential IOL that was required of 85 diopters. He spent 10 minutes doing the capsulorhexis and then found that his AC was shallowing. He called one of his VR colleagues in to go and do a vitrectomy to give him some space because the lens wasn't going in so easily. The VR surgeon did the vitrectomy, but found that all 3 ports were through the retina. The patient got a total retinal detachment and ended up with an NPL and painful eye. Here are some other eyes that are similarly likewise, but you can see a good result here after the lens has been taken out. So there are certain precautions and intraoperative difficulties that you need to get around with these eyes. Of course, you have to have these tight corneal incisions, and the AC depth must be maintained and monitored at all costs. Remember to fill your AC again and again with viscoelastic, or use the AC maintainer, especially when you're doing your rexes, which may take you a lot longer than expected. Any drop in pressure in the AC may promote a serious or hemorrhagic choroidal detachment, and sclerectomies will often be necessary if those are at risk. You may even need to go off and do a prophylactic sclerotomy, so go and pierce through the sclera and drain that choroidal if necessary. Sometimes you might use a soft shell technique with dispersive and cohesive viscoelastic. So there are certain things that you can help yourself with preoperatively or intraoperatively. So use that 20% mannitol. Do those clear corneal temporal incisions. Use Helon GV or Helon 5 if you have it. And use your Kawai forceps, which are low incision, so small incision forceps, so you don't need to widen the incision very much. And watch out preemptively for things like iris prolapse. So after you've given all these things and done your sclerectomies, there are several controversies at play. So is there a need for a limited pars plana vitrectomy before the cataract occurs to deepen the AC? Remember that cautionary tale, you might put in your ports through the pars, not through the pars plana, but through the retina. If you can do sclerostomies, who needs it and when? And the sclerectomies, the same thing. What size should be they, and what shape should they be? Of course, there's always a problem with endothelial cell loss. Should you use a soft shell technique to help you? And do you need to suture all the wounds? Well, the answer to that is probably yes. And the rates of PCR are extremely high in these cases. When you're looking at cases where the axial length is around 15 millimeters, the PCR rate is around about 50%. 18 millimeters, 20%. So here's a case that I'm going to go through with you with a 15.44 millimeter nanophthalmic eye with previous effusions. The other eye had gone NPL and lost vision because of effusions. So here's the look at the disc, and we've measured the sclera as well as being quite thick. I'm doing prophylactic these sclerectomies. And these are 4 by 4 millimeters square incisions that are done to basically decrease the pressure on the episcleral venous plexus. And that allows the AC to deepen. And it in fact does deepen when you do this. There are several studies done on this, and generally the perceived wisdom is that if you've had previous uveal effusions, it's safe to do these sclerectomies. If there's no effusions, you can leave them out. But remember, do them in the positions where the uveal effusions were. So if they're inferior, do them inferior. Do 1 or 2 depending on how bad you think they were. There's a very nice randomized control study which actually showed that in comparing those eyes which had a prophylactic sclerostomy versus those that didn't, and showed it was advantageous in causing less postoperative complications, especially the risk of developing a uveal effusion. Here's the rest of the surgery. You can see I'm making very short tunnels, long tunnels here, and I'm making the CCC with a needle, something that's low profile, using a Kawai, not a Utratus here, to do the rhexis. Making it quite large here. It looks quite large, but actually the eye has a microcornea. The cornea is quite short. The iris hooks in to hold the iris back because the pupil was small. Once this is done, you can start off with your phaco. Fortunately, the lens is not very dense in this particular case, and the phaco goes well. I'm using the IA to get rid of the last pieces here. When you put the lens in, you have to have a look at the back of the eye. Are there uveal effusions occurring? And this is where I do the BIO. And I put in lots of sutures into the incision here to stop any future shallowing and malignant glaucoma occurring. There's a whole talk I can do about the choices of IOL and how to place them, but essentially you need to go and put either the biggest IOL that you can put in and use a piggyback technique to put in a secondary IOL, usually in the sulcus if you can't fit it in the bag, or you can get custom-made IOLs. And I won't be dealing with this problem at the moment or with the problems of the biometry, but suffice to say that in the ones that I've done, it's probably best to go and put a biggest lens you can in the bag and then put something else in the sulcus. And there are several different ways of calculating this as well for later on. Now, the problems that can occur are obviously multiple. You can get anterior uveitis, uveal effusions, corneal decompensation, retinal detachment, cystoid macular edema, choroidal hemorrhage even, vitreous hemorrhage, and aqueous misdirection. Now, a lot of these can be avoided with good clinical practice before and intraoperatively. And of course, if you know these are going to occur, you can look out for them in the postoperative period as well. Generally speaking, though, if it goes well, it will continue to go well in the postoperative period. The rates of malignant glaucoma are high, as is vitreous hemorrhage, and you can just wait for these to go away by themselves, hopefully. There is a very high rate of posterior capsular rupture, as we explained earlier on before, and again, the need for anterior vitrectomy. In this second study, actually done by a group from the US, you can see that the incorporation of a PI and anterior vitrectomy actually led to less of these postoperative complications occurring. In the second paper, no sclerostomies were done during the surgeries. So basically, in conclusion, it's very important to use our tools of imaging and surgical technologies to improve our success rates. And we've actually done very well more recently with the success rates in these individually challenging eyes. So nanophthalmic eyes do represent a significant surgical challenge with a very high rate of intraoperative complications. And of course, our biggest problem to date is the unpredictability of IOL power calculations. And actually with these, we actually do much better now with the newer formulas, and we're getting our eyes to see better. Thank you very much.
Thank you, Professor Shamira, for enlightening us how to deal with such a complicated situation of nanophthalmos.